Hello, I'm Jovial Thomas Ntawukuriryayo. I'm a public health professional working at University of Global Health Equity as a research assistant. I am now happy to present a research study results from the wider research, which is implementation research. And this study is titled Understanding Geographic Equity in the Coverage of Facility-Based Delivery in 6 exemplar countries. Between 2000 and 2015, Nepal, Rwanda, Peru, Bangladesh, and Ethiopia successfully reduced the under 5 mortality faster than regional and socio-economic peers through implementation of evidence-based interventions known to reduce under 5 mortality. Based on this performance, these countries were then called exemplars in reducing under 5 mortality. Despite the success, high national coverage of evidence-based interventions does not always mean equitable coverage across every country. As a research team at University of Global Health Equity, we completed implementation research case studies to understand how these countries implemented evidence-based interventions to reduce under 5 mortality at national and subnational levels. For this research, we are presenting results of facility-based delivery as it requires trusted health system and is critical for reducing neonatal and maternal mortality. What methods did we use? As demographic and health survey reports, DHS contain national and subnational coverage data. For each of these countries, we extracted the facility-based delivery data from the DHS reports and compared the coverage data for around 2000-2015, depending on when the report was published. For each of these countries, we also calculated the absolute equity gap in facility-based delivery across geography, which is the difference between the highest and lowest subnational coverage. Implementation strategies and the contextual factors, which include both facilitators and the barriers that facilitated or influenced the equity in facility-based delivery coverage, were extracted from the implementation research case studies. Between 2000 and 2015, we found that the facility-based delivery coverage increased at both national and subnational levels. However, this coverage varied across geographic regions within the same country. Let's have one example of Ethiopia, where in 2000, the lowest subnational coverage of facility-based delivery was 3%, while the highest was 67%. The same country in 2015, the lowest subnational coverage increased to 15%, and the highest coverage increased to 97%, almost 100. Another example is Rwanda, where in 2000, the lowest facility-based delivery coverage across the provinces was 21%, and the highest coverage was 71%. In 2014, this country had the lowest subnational coverage increased to 89%, and the highest increased to 94%. In fact, the facility-based delivery coverage varied across the subnational regions. Looking at the absolute equity gap, which is the difference between the highest subnational coverage and the lowest subnational coverage, it varied within the countries. The absolute equity gap reduced for Rwanda and Peru and remained almost unchanged for Senegal, where it kept increasing for other countries. This gap dropped by 90% for Rwanda and by more than 50% for Peru. However, the absolute equity gap for Bangladesh tripled and doubled for Nepal and increased by almost a third for Ethiopia. The facilitating contextual factors included strong leadership and commitment, where, for example, in Senegal, the leadership prioritized free delivery policies for pregnant women from remote areas. And for example, in Rwanda, the facility-based delivery, along with other maternal and child health indicators, were integrated into the performance contracts of local leaders. The barriers included geographic obstacles and cultural beliefs. For the geographic barriers, where some pregnant women from remote and hard to reach areas had to go or to make longer distance to travel to health facilities for delivery, for example, Bangladesh and Ethiopia. And as an example, in Bangladesh, the cultural belief was also a barrier where some people in rural areas had conservative norms, and men had to make decisions of going outside for women, for example, for seeking healthcare services, such as delivery in healthcare facility, or in the hands of an unqualified traditional birth attendant. The implementation strategies that facilitated the equity gap reduction included health system strengthening through decentralized healthcare facilities, the creation of free facility-based delivery policies, and building on existing community health program, where, for example, in Rwanda, community health workers could accompany pregnant women to a health facility for delivery, or call ambulance in case a woman presented danger signs. Another strategy is the creation of maternal waiting homes near health facilities. For example, in Peru, where pregnant women from remote areas could go and stay within the maternal waiting homes by the time they were nearing their due date to deliver, so that they can deliver in healthcare facilities. Concluding, the changing geographic equity gap in facility-based delivery coverage varied within the countries where, varied within the countries who were leaders in reducing under 5 mortality. These countries need to use implementation science methods to identify potential barriers, and of course, strategies to address subnational inequity in the coverage of evidence-based interventions. Thank you very much for listening.